and 4,000 children. So that was some of the statistics. There was a 20-minute national core content questions that were asked among the 9 regions. The topics that came out: chronic health, including diabetes, along with these others. And you see that these are also issues that show up in populations. Okay, so what we did see back, and this came from another diabetes researcher, Q Young. Dr. Q Young is now at University of Toronto. Okay, there's a smile over here, you're taking a course, all right. What we have seen with the, in the blue here is First Nations males, in the yellow is First Nations females, compared with the Canadian male and female population. We see the presence of diabetes in 15 to 24-year-olds. We see it, jump significantly at the 35 and 45-year-olds, and then very high at the elders for the men. We also see it high among young women, and then higher up here, just showing the diabetes, the age, gender-specific, and age-adjusted prevalence of the diabetes back in the mid-90s. Okay, here as well, more specifically, in the age group here, the First Nations female at a 12% is the population 35 to 45, the closest comparable in the non-native population at 65 plus. So just seeing the health crisis that's there with men in their 30s, the comparable rate of Canadian men in their 50s to early 60s. So you see this poor health at a younger age among these First Nations as a result of that this is the reporting from this particular longitudinal study that was done. And Jeff was, updating the audience, the diabetes, people working in diabetes back at this conference on what was happening. We have to be concerned that when we're identifying prevalence, that there's an underestimation. We know we can only determine that with the drink the sweet stuff test. And where they did perform these tests, they detected by screening 40% of all diabetes cases. We know in communities today that if we're diagnosing 12%, if we actually see that amount, that there may be the equivalent that's not being shown. And for a whole variety of reasons, no access to health care, to having these kind of statistics in some of the small communities. There's only a community nurse. It's flying communities. Hospitals may be hours away by driving. People don't go to medicine centers. And the darn thing about the diabetes with Aboriginal populations that I've certainly seen over the years is that people have diabetes and don't know it, and they don't feel it. And when they go into clinic and get tested, they're getting tested with their numbers in the 20s. And they're like maybe in their 30s. So, that didn't happen overnight. That's something that's been going on for a long time. When my numbers get up in like the 8s, I can feel it right away. The doctor says, well, your body is more sensitive. But for most of the population among Aboriginal people that I've heard the anecdotal evidence from nurses, diabetes workers, community health representatives, it's way more than we think it is in communities. So we underestimate the burden of the disease. Okay. For age-adjusted, for prevalence, again, the diabetes is high. This is the male is the blue, female is in the white. Okay, ratios. And okay, so chronic disease range from 1.5 to 5 times higher compared to the Canadian population. Okay, again, information that we know. Yes?
I was just going to add to the previous slide when you talk about the prevalence and how the 40% is probably really underestimated. Is when you do that test of OGTT, the diagnosis of diabetes is based on, so the glucose has to be greater than 11.1, or if you do the other test, there's another test, which is not a gold standard. It has to be between it has to be between 6 and 7. And the definition of the disease is based on whether having that glucose range would result in all those complications like nephropathy, retinopathy, and neuropathy. And they found that in Aboriginal populations, that the manifestations of those complications actually started at glucose levels of 5.6. So just the diagnosis itself and how that's made, the definition, that in itself is not sort of even capturing, what goes on in the Aboriginal populations.
Yeah,
That's for the standard mainstream.
right, yeah. So that great, is it the greater sensitivity because it's physiological or cultural, based? It still needs to be, I guess understood, but the bottom line is that once that diagnosis is made, you're going to see, not when the diagnosis is made, but that complications are going to start earlier, right? Okay. So it's understanding the degree of the epidemic, and the problem, not only for the individual, but also from the community level and the larger cultural level. And we also see a greater prevalence among women, excuse me. And chronic disease tend to cluster in the same individuals, okay? So one problem leads to another, Walking time bombs. Okay, we see a relationship with the cardiovascular comorbidity, ages 45 and above. Okay, yellow, people with diabetes only, diabetes and high blood pressure, heart problems, and diabetes and high blood pressure and heart problems. Okay, so high at these younger ages. So people living with this, how it survive, how do people survive beyond? Well, kind of we know that they don't. Okay. And this one here, I'm going to zip ahead of this, one, because there's lots of numbers, and I'm not going to try and figure it out for you, and I certainly know that the time is zipping. The point here being that we want you to see numbers, the examples that we have a health epidemic from the diabetes with the complications. I'm going to leave that. Here, my doctor research non-existence comes to the forefront here. You've caught me. Okay. As well, women and men, again, the higher rates among the women than men. And some more information here on prevalence. Okay. The prevalence has increased by 50% among status and non-status Indians living off reserve, which is now about 50% of the population, of the First Nations population, is living off reserve. I was just reading that. And 1 in 12 off reserve and non-status Indians state they had been diagnosed with diabetes compared to 1 in 20 just 20 years ago. And this was, so this was 10 years ago, so 2001. You know what I mean, thereabouts, 10 years before that. Okay, the percentage of Métis and Inuit adults diagnosed with diabetes showed for Métis adults, 1991 rate of 5.5% increased to 6% in 2001, just in 10 years. And among Inuit, increased from 1.9% in 91 to 2.3% in 2001. And now it's 2011. We know, we're assuming that numbers have gone up, and there's more, there hasn't been any national studies done since 1997. There's been smaller, more regional studies, community studies. Stuart Harris just did a circle, what they call the circle study, looking at diabetes in, I think it was 10 First Nations communities around Canada, and then doing a comparison, and lots of similarities, but of course, numbers going up. Numbers going up. Okay, 8.5% of First Nations people on reserve have diabetes. Okay, and 5.5% of Métis have diabetes. Okay. Quickly through this here, I'm going to jump through all of these slides, but we just know that the social oh yes, sorry.
Just a quick number in regards to numbers. Do they change in regards to whether or not you're considered status or not status Indian, or whether or not you're living on or off reserve? Like, are the numbers comparable, or are there differences higher or lower?
I think I think that the differences are probably small, but everything is moving up, and the specifics, I can't speak to that. I don't know.
So I've traveled to a number of the communities that they've done longitudinal studies for, Sandy Lake, Fort Severn, Kingfisher, Poplar Hill, and one of the things that I see is that the northern store that is the only store there, they sell pop for about $6.99 a liter, and they also sell maybe vegetables for $5.99 a pound. People still buy them, and I would like to know if there are any recommendations on how to absolve that crisis, because diabetes is evidently from the regular consumption of diet or sugar-based products, because the water in the community isn't safe to drink.
Mm-hmm.
So how do we go around that? And also hunting is a problem because MNR, Ministry of Natural Resources, has their issue on how to hunt, where to hunt, and sometimes there's a lack of, I think, migration for specific species as well. There's less moose when I went there.
Yeah, hunters followed the herds, and our concept of land is different, and we didn't have borders, but now we're fenced in, literally, rules, regulations, etc., and all of that comes to play. When we talk about the social determinants of health, just what you're raising here is indicated in the different topics that are about the social determinants of health, okay? All of these impact, okay, our physical environment, the social environment, education and employment, income and social status. When milk costs $6 a liter in a fly-in community, $6 a liter, yet the 2-liter Pepsi is going to still be at $6 as well. You're going to get, everybody's got to drink something at the supper table, the 5-pound bag of flour versus, whole grain breads or other maybe whole grain products that people consume. Also eating out of what you didn't eat before. We didn't consume all these carbs that we do today. Impact of the biology and genetic makeup of people, the influence of culture, what kind of health services are available, gender issues, people's coping skills, and health practices, whether they're contemporary health practices. You're talking about compliance when you're going to when you're trying to get people to understand. Same thing within the traditional medicine perspective. People complying with that, working with that. What kind of support networks are in existence? Education linked with child development linked with education. If this is the informal, what's not learned in school but passed on from generation to generation. All of these play a big part in what determines health. And we can go to each of these things and talk about diabetes and how each of these things there's problems in there. There's problems in there.